our thought was, I said 30 days after discharge, and I got shot. So we decided that we would go to 0 days, and that wasn't very good either. We settled on about a week, thinking that it would be, we don't want somebody to send a baby home if they've been feeding on full feeds for, 12 hours, but we don't want them to stay in the hospital for 3 weeks either. So that was, any input that you guys have would be very much appreciated.
Aren't newborn screenings mandated either by law or by health department regulation already?
I don't think there's a certain standard of care, and this is not at all trying to replace that standard of care. And I think that whenever we get to the quality metrics portion of this, it'll clarify that a little bit. And as far as the 90% screened or not screened, everybody should be screened, no matter when you're born or whatnot. So I don't think that was an actual number that we've discussed, but to appease some fears. But I think that standard of care will still be expected, and maybe even more so once we better define our episodes.
Yeah, that's the goal, and if you guys see areas to make sure that that is highlighted even more throughout, please let us know. Let me just, for time, there are a number of things we need to get to, so I'm going to move us to page 35 on the quality metrics. Just a reminder, David Greenwood introduced the quality metrics at the beginning. These are really to ensure that there is a cost incentive here, but that high quality care is being delivered. In some cases, for some episodes, some of the metrics, again, are also to provide transparency to the provider who might find it helpful as they are caring for a population of patients to understand where their data stands, where follow-ups are happening, and so on. So 35 has a starter list. You'll see a set of metrics at the top that are claims-based metrics, meaning the payers can identify these today through payer administrative claims data. You'll also see a set of metrics at the bottom labeled provider portal metrics. As many of you know, there is a statewide provider portal. Some of the other episodes are using that, where office staff would have to input certain metrics that are not otherwise available through administrative claims data, and those would be included if, as a group, the payers, and especially with input from others, would feel that those are particularly important quality metrics to track, regardless of whether they're in the claims data or not. So you'll see on this list, some of these are pulled from the Vermont-Oxford network, some of these are pulled from interviews with others. You'll see things ranging anywhere from, there's length of stay at the top, BPD, NEC rate, IVH rate, ventilator-associated pneumonia rate, percent of patients intubated, percent of patients on CPAP, the percent of transfers for facility for full-term births, the neonatal transfer rate for a particular facility, the mortality rate in a particular facility. On some of the provider portal metrics, there's the CLABSI rate, late sepsis rate, weight gain rate, neonatal vaccination rate, some of the major complications that could happen in an episode that might be provider portal and indicated. There's some others that could be claims based. And for example, the suggestion I heard someone had before about screenings, we should discuss, for example, if screenings, EPST, other things like that would belong in the list as well.
What does percent of patients intubated, what's the denominator? Is that gestational dependent, and given our ability to apply Ensure ICE to babies and avoiding central line sedation, probably considerable morbidities associated. Just wondering about that percent of patients on continuous positive airway pressure, and how the payer is defining ventilator associated pneumonia, and what's the denominator? So a lot of questions on all that.
I think on some of these, I'll take a stab because as I mentioned, these are all still under discussion. Some of these, not every single one of these metrics on the page has been fully defined. Some are more defined, especially ones that others throughout the country have used as well. Vermont, Oxford, for example. But some of these, for example, are things we've heard from clinicians as something that would be good just to track. Not necessarily would have anything to do with payment, but just so someone could have a view into the percent of total patients, for example, within the population that are intubated as a fact for the clinicians. So I think that's where we're starting right now. If you have suggestions on a particular, on a more meaningful way to shape that metric, or whether that's meaningful or not, we'd love to hear.
Intubated days as opposed to intubated, because it's very frequent to intubate a baby, give surfactant, and extubate in the delivery room.
Okay.
So I would not use percent of patients intubated, maybe intubated patient days, something along those lines.
Great, thank you.
One of the things that we discussed was to, pick top 5 of things that you thought were important, and that was that very thing was actually one of the things we discussed additionally. And the other concern that I've got is of ventilator-associated pneumonia in the neonate, and I think the diagnosis for that is very unclear, and so I would be in favor of throwing that one out. And then the others, I think, all have to be adjusted for the gestational age. That was sort of my thinking on it, but would be very interested in your top 5 and any that you'd like to throw out.
I'd like to throw one out.
Please, go ahead.
The state is encouraging breastfeeding, and it seems like that actually does impact outcome in a lot of ways and increases costs. So it seems like providing some sort of breastfeeding use number would be useful.
In the claims-based metrics, ventilator-associated pneumonia rate, percent intubated, percent on CPAP, is that under proposal to be in claims or to be in provider metrics? That's in flux, as I understand it.
It would all depend on what is actually accurately tracked through administrative claims data today. As we go through this and find if it's accurately tracked and the payers can see that, then it would be claims to reduce administrative burden for providers to have to input that. If there are questions for how well that's tracked or certain screenings, in the perinatal episode, for example, the payers start with administrative claims data, but some practices in the state have noticed that they may still be doing some of the screenings that are not being catched, so they have an option, for example, to further enter and supplement that data through the provider portal if they believe the administrative claims data is not catching all the screenings and other tests that they're doing as well. So I think that whole spectrum of options would be on the table as this list gets refined to the set that the payers would actually go out with.
When you look at the universe of claims that these infants generate, the respiratory claims are almost as extensive as the inpatient claims. Isn't that correct? So there's a lot of detailed granular billing by respiratory therapy, et cetera, connected with these activities.
Any other suggestions for metrics that are not on the page that the payer should be considering? A quality perspective? Any other things on the page where the definition of them the payer should take a keen eye to understand exactly what as the question before, what's the denominator or any issues with any of the metrics?
And again, to be clear, in case, because some of the comments earlier, the purpose of the quality metrics would be as a criteria to pass to qualify for gain sharing. It's not for payment of the regular claims. It's just to be able to qualify for being gain sharing. So we're not looking for perfection, but we're looking for just some evidence that the basic standards are there.
You'll see on the left-hand side just a reminder of the context for how the payers have thought about the principal accountable provider, and that is really the provider, whether it's a facility or an individual performing physician or surgeon or a medical group that really is in the best position to quarterback care for the episode. I think the payers have also discussed in certain episodes, under the right conditions, there might be co-PAPs, where decision making is appropriately split, and really it's a kind of team across 2 PAPs. So that really is the intent. And if you look at some of the other episodes that have been rolled out, an episode like CHF, currently under proposal COPD and asthma, in those episodes the facility is the PAP. because a lot of it is about readmissions and discharge coordination and making sure that entire kind of facilities has the right protocols in place with different performing physicians to really improve overall readmissions and so on. In some of the other episodes, whether it's perinatal or some of the cardiac ones that are under discussion, the performing surgeon or the delivering physician is the PAP. So the question in this case that the payers are still thinking through are whether it's the facility as the PAP or the medical group, the neonatology or other pediatric medical group or co-PAPs, what really is the most appropriate for this episode. And I think there are kind of a number of considerations on either side. So that's what we wanted to discuss today. Page 41, just to make sure we all have the same understanding of the structure of providers care for the neonate, and this is not an exhaustive list across every provider that is touching the neonate. At the top there are the direct physicians, whether they're the neonatologists or pediatricians providing care, and that could be a single physician that's largely responsible for the care of the neonate. That could be someone who is, operates in the solo form. That could be someone that operates in a practice but has primary responsibility for the baby with coverage from partners when he or she is not available. It could be a physician group that is sharing responsibility for the neonate with several neonatologists or pediatricians rotating in and out for care for that baby. Or, very seldom would you have multiple physicians across multiple groups caring for a baby. For subspecialists, whether that's the cardiologists, other folks providing care for that neonate, a subspecialist that's affiliated with the same group as the neonatologist or the pediatrician. In some cases, you may have actually an independent subspecialist that is brought in for consultation and so on. And lastly, the facility that is providing care for the neonate. So this is kind of the understanding we've had across the different permutations of physicians, subspecialists, and facilities interacting with or kind of quarterbacking care or providing care for the neonates today. I just wanted to pause here and see if folks have any comments on, are there any other situations that are not captured on the page? And again, I would recognize that this does not include every clinician that is touching the neonate today and providing care.
Right now I'm practicing more or less on my own out here, although I'm in association with Children's UAMS, but we will from time to time have locums, and I know the hospitals in Texarkana are relying pretty heavily on a particular locums physician as well. How do locums fit into that as far as, you mentioned something about, unusual for multiple groups to be caring for the same baby, but in the case of where locums physicians have to be contracted to come in to give somebody time off, that does actually kind of throw a wrench in that.
Can you describe how the billing of that would work? Would there be separate billing, or is it all billed under kind of the same medical group, but the medical group is figuring out contracting with others to provide coverage and so on?
Right now, what St. Bernard's is doing is they're just eating the cost because it costs so much to get the other provider enrolled and so forth. So whenever a locums comes to provide for me for a weekend so I can have some time off, St. Bernard's is actually just eating it right now. But if I start having the locums provider come in more and more, they will have to bill it separately because this is not a person who's from UAMS and Children's, which I'm affiliated with. So it gets to being really muddy, and so far they've just elected not to try to muddy the water so much.
Yeah, and just so we understand, is there an instance in which they are submitting separate bills, claims that are being paid so that there's a separate billing or provider ID to the payers, or is it all under that same medical group and that medical group is making subcontracting decisions, so to speak?
What my understanding of it is right now, and I'm not in administration, so I can't really tell you for sure, but from my understanding, the couple of times that they've had this particular physician cover for me, they've just not billed for those days because I haven't been here, so they haven't been able to use my provider ID. So they've just not billed for days and just eat the cost.
Well, if they're not billing, that would mean your episode costs are going to go down. So you actually come out ahead on that deal, it sounds like to me.
Understand, but what I'm saying here is, in the future, for instance, if they were to use her more, or if other hospitals are using a similar model where they're using a lot of locums coverage, they could have multiple physician groups submitting claims on the same patient. It could become a very sticky issue.
Yep. Okay. Thank you for that. That's a great. So we'll make sure as the payers are kind of looking through the historical claims data to really and determining what the decision rules for this would be, so to speak, to determine the PEP. I think that's going to have to be taken into account. And I think there was a comment.
Quick question on your setup. Are you employed by the hospital and your billings go to the hospital, or are you an independent biller? And if the locums come in, would they be an independent biller, or would they bill on behalf of the hospital? Do you have any framework on that?
I don't have a lot of framework other than to say I'm actually a provider of UAMS and Children's who contracts with St. Bernard's, but right now I'm the only one out here in Jonesboro. So
you bill. So when you bill, it goes to the Children's billing system. Is that correct?
When I do, yes, sir. And then the facility here bills separately for the facility charge.
See, that gets into, again, if there is a umbrella billing mechanism, it would all go to the umbrella billing mechanism that would cover the locums and probably be the whole setup in that regard.